Isn't it very exciting to be here to talk about something new in the 75th year anniversary of the first IOL implantation? I would like to talk about our advanced technology IOLs and the current challenges we are facing. So the main issue remains the compromises associated with the diffractive and light-splitting optics those lenses have. As you all know, those diffractive lenses have concentric rings that are splitting the incoming light into multiple foci, which is causing some problems in our patients. One of them is this photopic problems. So some of the light that is coming to those lenses is misdirected and not focused on the retina. The not focused light creates disturbances like halos and glares. So these are particularly problematic under low lighting conditions when we are driving at night, which is a huge concern for many of our patients who are seeking for spectacle independency. One other challenge will be the contrast sensitivity loss. So the additional split into multiple foci further reduces the already compromised light usage. The reduction in light intensity leads to a decrease in contrast sensitivity, again, when our pupil is large, which is very, very problematic in many of our patients. What we want is happier patients, more satisfied patients. How do we learn if our patients are satisfied? Well, RayPro is an amazing tool. We are hearing directly from our patients. And RayPro showed us that the patient satisfaction following cataract surgery is actually significantly affected by these photopic problems. The impact of this photopsia on satisfaction was found to not decrease, but strengthen over time. And the presence of this photopsia was found to be an indeed more significant determinant of patient satisfaction than spectacle independence. Can we reduce all those compromises? Today, we will try to find out.
So the RayOne Galaxy IOL, the spiral IOL, was developed in collaboration with Dr. João Lira from Brazil, who worked a lot of time on this project, and we're happy to have him here with us today. So what is it about? It's a lens that will provide a full range of vision with less halo. This is the main objective. It's not diffractive, it's refractive, which should induce less dysphotopsia with using all of the light, so 0% of light loss. It's already available in toric powers, from 5 to 30 diopters for the spheric powers. So what does it look like? This is how it looks like. You have a center for distance vision, and then the spiral refractive power this way. So different power, each color here is a different power. It uses artificial intelligence to be able to perform those spiral to make sure to have the best potential outcome for the patient. And this optical concept allows you to get a precise control of the optical power from near to distance, so a full range of vision, very smooth defocus curve. This is how it looks like in the OR. I had the chance to perform 3 cases a few weeks ago. This is a trifocal lens, and this is a Galaxy toric lens inside the eye, so you barely can see the spiral, as opposites to any diffractive pattern where you can see the difference, the diffractive steps. There is no discontinuity here, a very smooth optical surface.
So I'll be presenting the preclinical results which were performed on healthy subjects. And it was performed using a RALF device. The RALF device stands for Real Artificial Lens Vision. And this was developed by Decimal Limited in collaboration, and the study was performed in collaboration with Dr. Wolfgang Brezner from the Austrian Center for Medical Innovation and Technology, and together with Professor Michael Amon at the St. John Hospital in Vienna. So this device is a non-invasive system for the subjective prediction of achievable vision after the implantation of an IOL. It is not a virtual simulator. The subjects actually look through a real IOL. So the subject can look at different IOLs with different optic designs. And the main benefit is to enable an individual to directly compare their visual experience across multiple lens designs. So it enables us to be able to see preoperatively what is to be expected in the side-affecting state. The study, the RayOne Galaxy, was included and compared to the trifocal lens and the RayOne EMV. The measurements were done monocularly on one eye, on the dominant eye, and the visual acuity test was done at 4 meters, intermediate, and at near. The contrast sensitivity, defocus curve, and the halo and glare was performed at distance with best corrected visual acuity. At the end of the investigation, the patients were asked to choose which lens they prefer, so subjective lens preference test was performed. So as I mentioned before, the subject sits before the device and has a knob which they can turn and choose the position which is necessary to choose what they are seeing. And when they press it, it's documented in the device. So first, they had a visual acuity test performed at 4 meters with a Landolt C-ring, and they turn the knob so far as to orientate the dot in the direction of the open C-ring. And once they press this feedback device, the test goes on and the C-Landolt ring grows smaller until they cannot see that anymore. The next step was the contrast sensitivity test, where the C-Landolt ring was at an optotype size of 0.25 decimal, and the brightness of this, or the contrast of the C-Landolt ring, decreased with every step they take. And lastly, the halo glare test was performed at 4 meters. There's a light source with a halo of about 10 millimeters, and an optopipe is presented at the periphery of the halo. And this optotype is presented randomly from 0 to 9, excluding the number 8, and this number moves in concentric direction towards the center of the source. And once the subject cannot see the number anymore or recognize it anymore, that's the end of the halo test, and they can measure how far away it is from the light source. After a short break, they have a subjective preference test where they can choose between the trifocal Rayner lens or the Galaxy spiral lens. So for the intermediate, they had a tablet presenting a map, and for nearby, they had a WhatsApp text. So coming to the results, these are the monocular visual acuity results. The black column represents the Galaxy IOL, the spiral IOL, and we can see that it showed excellent distance, intermediate, and near vision, comparable to the trifocal lens, somewhat better in the close-up, and there was a significant difference in the intermediate distance. The monocular distance corrected defocus curve. Once again, we see excellent distance vision with LogMAR, presented in LogMAR. We have a full range of vision, and that's comparable to the trifocal IOL, but we have a better intermediate visual acuity with a smooth plateau between 0 and 2.5 diopters for the Galaxy lens as compared to the trifocal lens. The gray curve represents the EMV lens. Mean contrast sensitivity. The spiral IOL showed better contrast sensitivity as compared to the diffractive trifocal IOL. And coming to the halo test, this is quite impressive. The Galaxy demonstrated a halo size almost the same size as that of the enhanced monofocal EMV lens, and the standard deviation of both lenses were overlapping, and there was a significant difference to the trifocal IOL. So this is quite impressive. And lastly, the subjective preference test. They were asked to compare between the trifocal lens and the spiral IOL, and here we can see that most of the subjects chose the Galaxy spiral IOL over the diffractive lens. So lastly, coming to the conclusion, we can conclude that there is a similar visual acuity at far, intermediate, and near as compared to the trifocal lens. The visual range of extension is comparable to the trifocal lens with a better intermediate visual acuity with a smooth plateau between 0 and 2.5 diopters. Overall, there was a better contrast sensitivity as compared to the diffractive lens and significantly less halo than diffractive trifocal, and the halo size closer to an enhanced monofocal IOL than a diffractive IOL. So the Galaxy spiral IOL was the preferred IOL.
So this what we're going to show you is a post-market real-world evaluation. It was done at OCL Vision. I've now done 10 implantations bilaterally, so that's 20 eyes total. But I'm going to present the results of 7 patients and 14 eyes who have come back already now for their 1-month follow-up. And that includes both the RayOne Galaxy and the RayOne Galaxy Toric. Patients came post-operatively to have visual acuity measured, optometric refraction, defocus, and a halo and glare simulator. So what are the demographics? Well, half of the patients that we operated on had cataract, and half were lens replacement patients. And one of the nice things about lens replacement patients is that they don't know any different in terms of really good quality of vision in theory. So you're not replacing a cataract with something else, you're replacing a good functioning, or not perfectly functioning, but at least at distance, a well-functioning, in theory, natural lens with whatever the lens technology is that you're using. So they're a really useful group of patients to understand about dysphotopsia, about patient satisfaction, and half the results I'm going to present to you today are within that. You can see that that's reflected in the preoperative visual acuity, which ranges from -0.2 corrected logMAR to 1. And we included everyone, so it was just consecutive patients who would otherwise have had a trifocal lens were given the opportunity of having the Galaxy lens, and that includes myopes, low myopes, hyperopes, patients with astigmatism. No one was excluded for refractive reasons. The cylinder is tightly controlled, so the astigmatism works well, which is what we'd expect. The RayOne monofocal toric, that platform has been well used and showed to be rotationally stable over the last decade or more, so it's what we'd expect. The postoperative manifest refractive spherical equivalent refraction is a little bit minus here at 1 month, so at -0.3. And that probably reflects the fact that we were choosing the closest negative number to 0 rather than just the closest number to 0, or possibly the closest positive number to 0 is what we should have been using. So I don't think there's any need to change the A constants, but in this first evaluation, we're a little bit in the dark with respect to what we are able to achieve. So I would advise surgeons that start to engage with this lens to just choose the lens power that gives you the closest number to 0, even if that would leave the patient plus 0.1 predicted, would give you the most tight post-operative refractive outcomes. And you can see that across the whole range of vision, both uncorrected and corrected are excellent. So patients are essentially 20/20, logMAR 0 or better at distance, intermediate, and near. And as you would expect, when you look binocularly, where you have the summation effect of both the lens working in both eyes together, you see that's even better. So now they're performing at better than 20/20 or 0 logMAR, and the minus numbers, -0.06 for distance, -0.04 for intermediate, and -0.1 for near. And it just shows almost a plateau between +0.5 and -2.5. And within those ranges, patients are seeing 0.1 logMAR or better. And it really only starts to tail off below functional vision at a defocus of -3 or more. So it's giving patients a full and natural range of vision at distance and intermediate and near. How about the halo and glare simulator? Well, this is not something that we've just put together for a nice slide. This is actually what the patients told us they were seeing post-operatively when evaluated with this lens already in their eye, compared to published data with the trifocal. So we show them various degrees of halo and various degrees of glare up to about 100 severity. They select how things look to them in those ranges, and then we've shown that here as a mean. And what's really astounding is that half of the patients, and admittedly it's a small cohort, we're only presenting data on 6 patients so far, but within those patients, half of them reported no halo whatsoever. That's something that we all know is impossible with trifocal lenses. They all have halo. And the half that were reporting halo were only reporting mild halo and a very limited difference or no difference between their daytime vision and their nighttime vision. So the ability now to convert patients from a trifocal to the Galaxy lens is a very easy conversation to have, because you can tell people that they may experience halo, but that the halo will not be as severe as it would be with a trifocal, or that the halo is going to be mild, which is much more accepted by patients, and obviously for good reason. So in conclusion, my experience is excellent monocular and binocular vision at all distances. Full range of vision extension with a smooth plateau between +0.5 and -2.5. A binocular defocus curve showing visions of better than 0.2 logMAR across a range exceeding 4 diopters. a reduced halo and glare in the vision simulator test compared to published data of the diffractive trifocal IOL. Again, this is a non-diffractive lens, which is why when you look at the lens in the eye and you see the images, it's very difficult to see the spiral design. So there's much less reduction. In fact, there's no reduction in light loss with this lens.
My first patient, a female 56-year-old management consultant, has presented to me with failing vision. She does have reduced best corrected acuity of 6/7.5 on the basis of some lens opacity. I think, however, her main goal is to improve her vision overall, and in particular, the range of vision. Implanting a monofocal IOL, I do not think would deliver a desirable outcome for her. We discussed the available options and elected to implant the Rayner Galaxy IOL. Let's hear what her outcome was.
Didn't affect my long distance so much, but I couldn't read anything close up. And if my son handed me something, I'd have to say, "Whoa, take that back. I can't see that." From the moment I woke up, I reached for my glasses until I took them off at night to switch out the light before I went to sleep. I had glasses on. In fact, I was wearing my glasses all the time just to be able to read, my screen in my car for directions. I couldn't, for instance, pick up my phone and read it if someone sent me a text unless I had glasses on. I haven't been wearing mascara for some time now because I can't see unless I've got a magnifying 10 mirror right in front of me. It's incredible. I can see close up now. I can read my phone, read a menu, read the screen in my car when I'm driving, which I couldn't do before unless I had prescription glasses on. So yeah, brilliant. No, I don't appear to have any issues with nighttime. I haven't noticed any difference to before the surgery. Well, I'm not wearing glasses anymore. In fact, I haven't even tried to put a pair on because I wouldn't be able to see. I bought a brand new pair of sunglasses straight from the opticians without any prescription in them the other day. Brilliant.
My second patient, by contrast, was entirely different, an 88-year-old gentleman with relatively advanced lens opacity. He's arrived in my practice because his wife has brought him to me. She underwent surgery with me some 15 years earlier and has enjoyed full range of vision by virtue of the use of a diffractive multifocal IOL. As expected, she has experienced halos with this lens, but been very pleased overall with her outcome. I saw him at 3 weeks post-operatively. Over this time, he and his wife had plenty of time to discuss their visual experiences. And let's hear what he has to tell us.
I can read that very small print, which
Brilliant.
I certainly couldn't do before.
No.
I can read the paper and all that sort of stuff just by reading it.
Yeah. And do you read it on the table in front of you, or do you hold it up on the table in front of you? So that's really interesting because a lot of the near print that we deal with is at this distance, and if the newspaper is sitting down on the table, that's actually more an intermediate distance. So it shows that the range of the lens is very good. Yeah. What about the nighttime vision?
Yeah. In the car with car lights coming at me, well, Pauline was saying with her eyes, she gets a sort of, I don't know what you call it, a star.
Something like this. Yeah?
Yeah, that sort of thing.
Yeah.
Well, I don't get that.
Nothing at all?
No.
Cool. What about when you're looking at the forest in the distance? That's looking pretty good to you?
I can see the birds in the trees.
Okay. Do you think your vision has ever been better than it is now?
Not that I know of.
So Pauline's had surgery with me, I think about 2009 with Zeiss trifocals. And we're just saying that Pauline's got the halos, but Tony hasn't.
We were swapping notes on night driving, and I had this problem of stars and circles, halos around the lights coming towards me on the road. We've got quite a way to drive from the city out to the country. And I'd say, look at the lights. Can you see the halos? And there was no halos, was there?
No halos, no.
Except the brightness.
Just the brightness, which is pretty normal stuff.
So that's a bit of a compare, isn't it?
I think both of them have achieved their desired outcome. I think both of them will be spectacle-free for the rest of their lives. And they both have either acceptable or absent halos at night.